Many of our panelists had to sort of bounce through the skies of airplanes and planes, trains, and automobiles to get through the weather to get here, and we are really delighted that they made it. We're delighted that all of you made it. My name is Peggy Clark. I'm the Vice President of Policy Programs at the Aspen Institute and the Executive Director of Aspen Global Health and Development. And I'm really particularly delighted to be here today to welcome the panelists and to introduce Wendy Taylor, because this is really a fabulous report. It's fascinating. I really couldn't put it down. It's full of really rich stories, and I think you will all really benefit from our conversation today, as well as your own work with this guide as you move forward. This guidebook, this report, really marks a significant point in our efforts to explicitly address the challenge of moving life-saving innovations to scale in developing world contexts. And I'm honored to join with our partners, the USAID Center for Accelerating Innovations and Impact, and PATH for this high-level dialogue. This is the first of many discussions we hope all of you will begin around this work. I also want to give a shout out to the amazing PATH and Aspen and USAID teams for their hard work on putting this lovely event together, as well as the reception that we would encourage all of you to stay for. This work really is a watershed in terms of our increasing sophistication of how we bridge from an idea or an innovation to actual implementation on the ground. How can this be rolled out in a sustainable and an effective way? What is the difference between a brilliant idea and that first brilliant design to making it accessible to many, many, many people, particularly in high disease burden countries? So the dialogue today will ask the question, what prevents innovative technologies from reaching those most in need? How can leaders from diverse sectors and across disciplines move to greater coordination and effectiveness in terms of innovation, design, and rollout? And what can we all in the development assistance community and the private sectors learn from each other in terms of design thinking, operational assessments, market testing, and implementation? So as I mentioned, this report is really fascinating. The cases are terrific. While I knew that the HPV vaccine, for example, was a very interesting example of rollout, I never really understood the dynamics and what was behind the remarkable achievement of the initial rollout price of the HPV vaccine being $150 a dose and moving to $4.50. So what was the role of governments? What was the role of Gavi? How did this come to be? Another case looks at how strategic advocacy and evidence-based research on the ground led to the rollout of misoprostol to prevent postpartum hemorrhage. We all know about this incredible innovation, but what this report tells you about is it unpacks the story of how that came to be and how, after much resistance, the WHO approved its use in community settings. For those of you who are joining us, there's plenty of seats up in the front. Come and join us. Another fascinating case is about how the simple use of a particular antibiotic cream applied to newborn babies' umbilical cords finally came to be approved onto the WHO model list of essential medicines after a 7-year effort. And one that I particularly like, why the color cherry red is important in the design of an energy-efficient refrigerator. So these are really wonderful stories, and I think you will be delighted to jump into them. The Aspen Institute, for some of you who haven't been here before, is a great place to kick off this discussion. The Institute was founded on the idea that breakthrough solutions often come from gatherings of people from multiple disciplines, from art, science, business, public sector, private sector, and that this cross-fertilization of ideas is where we really can move the needle on things. This report is similar. It represents a very unusual gathering, as this panel does, of pharmaceutical companies, NGOs, ministers of health, community health workers, donors, multilateral institutions, all who together are identifying and articulating the steps in moving from idea to impact. So as I was reading this report, I kept thinking of the expression, where the rubber hits the road. So I looked up to find out what's the etymology of that phrasing. What does it mean? Where did it come from? And surprisingly, it's not where the rubber hits the road. It's where the rubber meets the road. And it was initially used in 1928 believe it or not, and it came from Firestone Car Company. And it was used when they were talking about how much braking distance you need to ensure that you won't hit that car in front of you. What was really the effectiveness of tires? And there was this expression where the rubber meets the road, because there was something that was happening that was quite different and complex from what the normal driver would think. And then, strangely, it also was used in 1957 in a musical called Rally Around the Flag Boys. And there was a song where they sang Where Rubber Hits the Road. So what I want to say for us today is, let's really use this time to dive into that, where the rubber meets the road and where idea meets reality. And many say that's where the hard work starts. That's where it gets interesting. That's where it gets complex. We have a fantastic group of speakers who will address that with us, and we really, really welcome your participation. So it's my honor now to introduce Wendy Taylor. I've heard so much about her. You know how sometimes you hear people's names, they say, you really like this person, she's really great, and their legend precedes them. And so Wendy is one of those people, and we're delighted to partner with her on this effort. She's the director of the Center for Accelerating Innovation and Impact at the U.S. Agency for International Development, which she founded and has grown in remarkable ways. She's had an incredible set of accomplishments. She spearheaded the Saving Lives at Birth Challenge, which was a very important challenge. She founded BioVentures for Global Health, a nonprofit working to engage the biopharmaceutical industry to develop medicines for the developing world. I also, just as an aside, want to say working with the center at USAID has been a huge breath of fresh air, and along with Wendy and David Millstone, we are really just looking forward to seeing what the next chapter brings with all of you. So Wendy, without further ado, thank you for joining us.
Wow. Well, thank you, Peggy. That was very, very nice. And thank you very much to you and to Aspen for hosting us, and Path as a co-host and partner. Heather, I think, has also been part of making this all happen. So we really appreciate the chance to be here. Very excited to be able to launch this nice report, and I hope everybody's getting copies because we want to sort of get this out far and wide. It's been a long time in making. And most importantly, I have to start with some additional thank yous, because it took a lot to get this out there. So I want to get those thank yous out there first. And so we worked closely with Path to put this all together. We knew early on we wanted to develop a framework, really help bring in some of the very best practices in terms of how we introduce and scale innovations, but we knew we wanted to actually make it real, and being able to develop case studies to bring a lot of these lessons to life was important. And Path played a really important role in putting together some of those case studies and bringing a lot to light. So Steve Brook, who you'll hear from, Heidi Lasher, and also Jen Fox, who did all the nice, beautiful design work. And then thanks to Emily and Ariana for helping do some of the back-end work on this event. And then, of course, the guide itself and the tools that go with it. Vinesh on our team did a lot of work on the tools, as well as Joe Wilson. And then, of course, our star of the show is really Dave Milestone, who drove it forward and is really responsible for putting this all together. So you're going to hear from Dave too, but I just wanted to get the big thank yous out there first. So we talk a lot about scale in global health, and certainly scaling innovations is not unique to global health. And I think we all are anyone who touches that in any way, we're acutely aware of how hard it is to scale innovations, regardless of what sector you're in. And we know certainly in global health that is no exception, and in fact probably has its own share of very unique challenges as well. Now, we certainly in global health have made great strides against some of our larger health goals, and that's in no part to our ability to actually scale some of these innovations and get them out there. And we've also made a lot of progress in getting in it. The beautiful problem to have is having a lot of life-saving innovations and interventions at our disposal to be able to help scale innovations. But one of the things that was very clear to us is that we have so many of these tools at our hands, but we're not able to actually scale them to the level we need to achieve the health impact. And this it's got a build in it. I didn't realize it was so this is a slide we use quite a bit, and it's just a really nice illustration to say in global health. And sorry for you guys sitting up here. Oh, very good. This Gates Foundation gets the credit for putting this together years ago, but we have a lot of innovations where in global health where we've sort of historically seen pretty late introduction after the point that it's available, and then pretty slow uptake and often low coverage as well. So we're not actually scaling these innovations to the level we need to be able to achieve our health impact. So introducing late from the point they're available, really kind of slow uptake, and then not reaching that impact or that target coverage. If you look at industry and you map this out against sort of a typical industry uptake curve, industry really tries to get to their target market in 5 to 7, 5 to 8 years. They're optimized around reaching their sort of peak sales and peak coverage very quickly. And to be able to do that, there's a heck of a lot of work that goes in years in advance before that product is ready, so that day one, that product's on the market, they're kind of off and running and moving that out. So one of the things that we are thinking about, and certainly as we kind of think about what we're trying to do in our center, is how can we continue to think about shifting these curves. And one of the things that we want to do is bring a lot of the thinking that industries, this business rigor, these processes into how to achieve that very rapid uptake. What can we apply from those lessons into the work we do in global health? And so one of the things that is clear to us, so if this is sort of where we typically are in global health, and this is not quite fair. We've over the last decade continued to do better and better. We're getting our products out the door faster. We're getting faster uptake. There's even examples in the guide where we've really scaling much faster. But we need to continue to do this better and consistently. So one of the thinking is, if we want to be from here to over here, what do we need to do to get there? So one of the things is really thinking about how we can have applying best practices in design and introduction and scale to be able to start shifting those curves. And if we do that, we think that we should be able to really begin to have faster introduction, faster uptake, and reach our target markets. But we also know that we're operating in some pretty tricky markets, and often that are filled with some market inefficiencies. And in many cases, we need to actually be able to take additional steps to think about how to address those market inefficiencies. And so many of you heard the terms market shaping is sort of the new term we're applying to some of this thinking, but often we have to address that market inefficiency to continue to shift those curves to the left and steepen them. So we've actually been spending time in our center thinking about both of these things. Today we're going to focus much more on this first one, but I just do a little shameless plug that we also just last month launched our market shaping primer, which is really intended to get at this second piece and how we can continue to think about addressing some of those market inefficiencies. So just quickly, when we think about why is this advanced planning so important, clearly faster introduction translates in a global health context, certainly translates into additional lives saved, and that is really some of our driving metrics. But we also know it's really important to get it right the first time. And industry groups and consultants have done a lot of analysis of product launch. This is some analysis that came out of IMS. And basically the point is that they've gone in and looked at that there's a short window of time to actually get it right. And looking at launch after launch after launch, if companies have a pretty short window to have a successful launch, and if they end up on this lower curve, you have a little bit of time to try to course correct, and if you don't course correct in that short window of time, you have a really hard time recovering. So I think the IMS study showed only 20% of the companies can actually recover. McKinsey's done some similar analysis, found some similar results. So this is for big pharma, this is developed world markets, but the theory should hold here in global health as well. So the point is to just say, with getting that launch right, planning for introduction is really, really important and can't be underestimated. So, so one of the things that when we set up the center, we really wanted to be able to bring a lot of this business thinking and rigor into how we better plan for product introduction and scale up. And we actually, as we started the work on the guide, we started to hold a series of several different labs pulling the private sector in, and did a lot of learning. And we started to look at all the tools that industry uses. And one of the things that became clear is a lot of these companies are using many of the same tools over and over and over again. And they even say, well, we're probably all hiring the same consultants. But these are tools that are sort of tried and true practices. So in this guide, we've done a lot of pulling these tools together, pulling the learning together. And what we've done is we've borrowed heavily from those, but we've also brought in a lot of learning from the global health community, from decades of experience in actually introducing and scaling innovations, and really thinking about how we can blend those two together to be able to bring some of the sort of best thinking to bear in how we introduce and scale. And I think Dave's going to walk us through quickly just some of what we've included in these guide and the tools themselves. But really, ultimately, our objective is to put a lot of these things into practice. But we also don't want to be sort of the late adopters, kind of bringing all the best ideas in to how we do our business. Kind of at the end of the game. We really want to ultimately position ourselves so we're on the front end of the curve, and that we're sort of continuing to push the boundaries of thinking, how can we more aggressively move to sort of optimize introduction, forge new paths, and get our products out there quickly so we can have the maximum health impact. So that's what we're trying to do here today. I'm going to hand it over to Dave, who's really got some of the nice meat and potatoes of the guide, and then we'll move over into our panel.
Hi, everybody. Peggy, thanks for the welcome. It was great to hear those kind words on the guide. We're certainly excited about it. And so before we get to the main event, I'm just going to quickly go through some of the contents of the guide to give everybody in here an understanding of what went in to create this, but also how you can start putting some of these tools into practice. As Wendy mentioned, it was over about a year ago that we brought together some private sector folks from medtech, pharma, but even outside of the health industry, combined that knowledge with some of what we've learned from global health practitioners, NGOs, and really tried to blend these best practices across sectors. And that was sort of the genesis. Because we understood that, I myself came from the med device industry and really had no idea of how complex global health was, from the number of actors, from the number of countries that you're dealing with. It's a complex environment. And so we wanted to sort of build some guidance and build some clarity around this delivery planning process to inform sort of how we work at USAID and potentially inform some of our implementing partners on all the activities that need to happen. Also, as we began to talk with folks, we recognized that young innovators and entrepreneurs could really benefit from understanding all the activities that have to happen in advance of a product launch. And then ultimately, some med tech and pharma companies have shown some interest in this perspective as well, recognizing that some of the fastest growing healthcare markets in the world are in sub-Saharan Africa and Southeast Asia. And so there's really this opportunity to blend some of that thinking. And we wanted to be strategic, so provide an overarching sort of perspective of all the activities that need to happen, but also be very practical. And so to that end, we created this idea to impact, one of three parts of which you have in your hands today. The first piece is sort of this case collection and framework overview that marches through about 18 different case studies and really tries to lend context to some of the activities that we're describing in the guide. We also have a practitioner's workbook for project managers to sort of track activities and progress over time. Then we also have what I'm most excited about because I think it's the most practical, which is this toolkit, a collection of tools and templates that practitioners can actually put into practice. So This is an eye chart, and so I'm going to stand here and be quiet while everyone reads it. That was a joke. But it's just to say that there's a lot of blocking and tackling that needs to happen. And as I've sat in on some of these global health meetings, everybody talks about these things, but in no particular order. There's a ton of activities and action taking place, but what we want to do is provide a framework and house all of these activities in an understandable way. And so that was sort of the base, and if you could think of it as the table of contents of this guide. And so for each stage, we've outlined sort of key activities that need to happen, not necessarily in any particular order, but need to be considered throughout this process. We've all seen studies and papers that have come out of Washington that can sometimes be more sizzle than steak. And so we've tried to ground some of these activities in practical lessons that are tied to these specific activities. And so throughout, we've seen 18 different case studies. We've got practical lessons for each of these case studies. We've tried to keep them short intentionally and really focus on the key lessons. And throughout, we've actually talked with experts from industry, from global health, from other sectors. We've talked with folks from L'Oreal, for example, on some of their supply chain expertise, and really cull out those sort of poignant lessons that all of us could learn from. The toolkit is the piece that I mentioned, sort of, I think is most practical. And so throughout, we've collected tools and templates that practitioners can actually put into practice. We're not saying that these are necessary, that you need to do these, but they're there for reference, and I think can stimulate some thinking and move folks down the path to understand different aspects of a delivery plan. So in addition to those tools and templates, we've also, what Vinesh and Joe were really helpful with is developing sort of a how-to guide, so beginning to understand how you could put these tools into practice. And then finally, this workbook that begins to bring together all these activities for a project manager, if there were a project manager on some of these projects, to begin tracking some of these activities and progress over time. All of this is available on our website at usaid.gov/CII. And again, what I can reference here, and before I introduce the panel, Wendy, you can come on up. What we've tried to do is outline a set of activities and tools throughout the various stages. So we've given sort of a roadmap of how you might put these tools in place, and I'll leave you with this, that this is very much a work in process, and so we're seeking your feedback, and we want you to put these into practice and tell us what you feel. Tell us what is working, what isn't working, so that we can continue to refine this and make this better over time. So with that, I'll hand it off to the panel, and look forward to talking with most of you after the session. Thanks.
Okay, and this is on. So we have a great panel here, and I'm going to do quick introductions. I think you all have their bio, so we will save some time and really get into the heart of this. So to my left, we've got Gary Cohen, Executive Vice President of Becton Dickinson, Krista Donaldson, CEO of DREV, a fabulous NGO that is breaking lots of new ground. Robert Fabricant, who is co-founder and principal of the New Design Impact Group at Dahlberg. And then also huge apologies from David, who was not able to make it, from David Reddy from MMB, who got all the way to London, and then his flight was not able to fly to the US and couldn't get here in time. But Steve Brook nicely stepped in at last minute's notice, and Steve is the Deputy Director of Health Tech at PATH. So great panel. So what I'm going to do is maybe just to get us started, get you all to just give really quick 60 seconds of sort of where you sit, why global health development is important to you, innovation is important to you, and also bringing it to scale. So just maybe quick 60 seconds.
Okay.
Eye on the clock.
So
my
I'm
watch.
As Wendy mentioned, Executive Vice President at BD, Becton Dickinson, which is a 118-year-old global medical technology company. I'm there 31 years. I made a decision some time ago to put all my effort towards increasing access to health services and technologies among resource-limited populations. And in addition to BD, I serve as acting CEO of GBC Health. I'm on the board of UNICEF. I'm on the board of the CDC Foundation. I'm vice chair of the UN Special Envoy's Office for MDG Financing. I was a commissioner on the UN Commission for Life-Saving Commodities for Women and Children. So I kind of live this stuff every day, and it's an area of great personal passion for me, and I'm thrilled that you're holding this panel.
You have more hats than anybody I know.
Fit my big head.
Krista.
So DREV is an impact-driven product company. We're structured as a nonprofit. We're 7 years old. We have 2 products on the market, and we've really been focused. We started out as kind of a general product development firm, but now we're really focused on medical devices and closing health and equity gap. And I would say our approach really is to find where's there the low-hanging fruit in healthcare? Where is there something that is easily developed, and things are not always easily developed, as most of you probably know, but we can work with partners to scale up and make sure these products reach impact. And we have 2 lines of products. One is newborn health, and we've been focused on phototherapy for severely jaundiced babies, and we just launched our 3rd product there, an update to Brilliance. Our first one's called Brilliance Pro. The Brilliance products have treated over 40,000 babies. Our 2nd line of products is around mobility, so for amputees who've lost their leg above their knee. And we're just about to launch a prosthetic knee. It's the 4th version. The first version is worn by over 6,400 amputees.
Excellent. Robert.
So I come from the world of product design in the private sector, and I'm here in part because product design is hard for everybody. It's not an easy thing, and whether you're working in consumer electronics, whether you're working in food products, it doesn't matter. It's really, really great, fun, exciting, but also challenging thing to do well. And I think we're going to be here wringing our hands about global health, but it's worth noting product design is hard, and really great products are few and far between. And I think here the need is so pressing that we feel this incredible sense of a deficit. But why I'm here is to bring some of what I've learned about design into not just healthcare, but particularly global health and other areas. Our group works across many different areas of development, and really trying to understand why some of the skills in quick and rapid prototyping, some of the skills in participatory design with both end users and other stakeholders, why it just doesn't seem to happen as often or as easily. And how can that happen a little more easily? And our hypothesis is that that's actually going to make product design a little bit easier for everybody in this room. So that's why we're here.
Great. And Steve?
Thanks, Wendy. I'm really excited to be here. And I think at PATH we've been trying to help educate the community about the need to do this comprehensive planning for a long time. We've had our good examples of it. We have our examples where we can learn and move forward too. I think what Dave said really makes sense, that it is really blocking and tackling. And being from Seattle, I wish we would have blocked yesterday, but oh well.
You just needed not to pass. So
Yeah, exactly. So
We feel for you.
thanks, Wendy, for the chance to join as a panelist, not just an audience member.
Great. Well, so let's pick up on what Robert said, which is and how I opened. This stuff is hard. It's really hard to scale well. So maybe just sort of quickly from each one of you. So what makes it so hard? What are the big pitfalls? What are the things that you really need to watch out for? And we'll be able to dive into these a little bit deeper as we go along. But just kind of your high-level view.
So I'd like us to have a basic construct in mind. Think about 3 levels, call them 3 market segments in business terms. You have people who have ample access to health services. I would estimate it's 20 to 30% of the world's population, more in industrialized countries, and among the wealthy in emerging countries. You have a middle population in emerging countries where there's a lot of economic development, there's more investment in the health system, they're gaining access to health services. And then you have another subsegment of the population that has little or no access. And here we're talking about reaching that 3rd segment, and that's where many of the challenges lie. Now, I'll cite one example. In 1988, UNICEF and WHO understood that the EPI, the Expanded Program on Immunization, which was so successful, was also resulting in disease spread among children due to reuse of injection equipment designed for single use. And they reached out to industry and said, help us with technical solutions BD collaborated with PATH, in fact, and developed the first auto-disable immunization device, which physically locks after a single use, thereby blocking the potential for reuse and disease spread. It took 8 years for that to go into broad use. They were commercially available in 1991. They went into broad use in 1999. The good news is, since 1999, over 5 billion immunizations have been administered safely with those devices. It essentially eliminated an entire category of disease spread. We learned a lot over those 8 years about what needs to be aligned. And just having a technology available is far, far from sufficient. In fact, we came up with a model in 1999 of 7 factors that had to come into alignment in order for a new device or technology for the developing world to go into broad usage. And I can probably rattle them off the top of my head quick, but I have my notes in my pocket if I forget. But advocacy to create awareness of the need. Appropriate technology means low in cost and appropriate for the use. Funding. The funding has to be there both to develop it, and when you're dealing in those market segments, there's not enough economic power to be able to secure access on their own. So there has to be advanced market commitments. Gavi happened to step in that circumstance and enabled it to happen. You need policy and guideline changes. You can get, in my estimation, of being a little general here, 25–30% of the way there in the absence of policies and guidelines. But at some point, either WHO guidelines or national laws need to change to enable further and broader use. You need to have training of clinicians. You need to have clinical data on effectiveness. And you need to be able to collaborate across sectors, because none of these issues can be solved by one organization or even one sector on its own. There's other things like supply chain distribution, of course, that you need. But if you get half of those, it's not enough. That was our experience. And we have several other experiences I could share as well.
Great. So that's a great list. Advocacy, appropriate technology, funding, markets, policy and guidelines, training, clinical data, partnering. So what did he miss?
Yeah, so I
add to that.
It's obviously it's very complicated, and product design and product development, like Robert said, is complicated anyway. I think from our experience, kind of picking the top 3, I would say alignment, which I'll talk about in a second, unknowns, and system. So number 1, alignment. In global health, you have a lot of actors. You have for-profits, you have patients, you have purchasing decision makers, you have funders. Getting everyone aligned on the same incentive to achieve the same goal is very, very difficult. And I think fundamentally compared to the US market, in a low-income country, you have some trade-offs being made against profit relative to the impact that you're setting out to make. So trying to get everybody aligned for a single common goal, I would say, is the first thing. The second is unknowns. We've really run into, related to treating children with severe jaundice. We don't think of it here as an issue in the West, but it's actually up to 90% of children in low-income countries don't have access to effective phototherapy. So that means either there's no phototherapy, this is just blue light to treat babies, or the devices there are ineffective. But the issue of morbidity, there isn't a lot of data around on brain damage resulting from kernicterus, the brain damage from too much bilirubin. So if there's not data, it's difficult to prove that it's a problem worthy of significant global health funding. And I would say data also extends on the other side around demand forecasting. It's very difficult to understand market sizes, to understand need, all these sorts of things if the data doesn't exist. And so we really see lack of data, and there's a lot of trying to figure things out, improvising, estimating market sizes and need from top down and bottom up. So my third thing is system. And this is something that I think the guide is really starting to tackle, and I'm really pleased about that. But typically in global health, I feel like things tend to start in the laboratory. And really what things need to start with is with patients and understanding who all of the users are, not just the end user, but the purchasing decision maker, and understanding all the constraints in the environment so that those product specifications can go to the designers and the engineers and the business people who are coming up with the whole model of getting a product to impact. And impact isn't just getting a product on the market, it's making sure it gets to the people who need it and need to use it. They're using it properly so the device isn't breaking and then getting shunted in a corner. And then, other products are coming to market too. It shouldn't just be a single solution. At the end of the day, you want patients and practitioners to have choice in the products that they want to use.
Great. Either one of you want to just add on?
Sure, I'll add a couple, and obviously these were great points. The things that strike me and stand out first is what you touched on, which is too much technical-based decision-making. too many people who are comfortable and satisfied making technical decisions and not necessarily thinking or taking ownership over broader market decisions in terms of the product and what it should be. And around that, a huge amount of effort into proof and measurement, and that somehow in that, the end user and a lot of the other stakeholders kind of get lost, and there's often a mismatch between the need that we see and the need that they see, and an assumption that a great need in the world in terms of health means there must be a great product to solve it. And then the last piece, also a little bit what Krista touched on, was just too much learning happening on one-off products, not enough learning carrying over.
Steve, you have the daunting task of being the last.
Last word, baby.
After the laundry list from the rest of us.
Yeah, you guys have covered the laundry list, so I'll move on to drying or something. But I was thinking about how we have some examples in global health where things have moved, but it's often, there are too many silos in a way. I mean, the immunization system can work to move things out pretty effectively because it's a gigantic global top-down mechanism. Family planning area, there's been some good success, but then we are dealing with maternal health and child health where it's a much more country-driven situation, so it's a more complex market in that sense, and I think we need to learn how to think of it in a more complex way.
Yeah.
And scale is going to look different in that kind of system compared to an immunization context, I think, and there's lessons to be learned both ways.
Right, now the MCH, having started working in global health with more of a focus on vaccines and then shifting over to maternal and child health, it seems as if suddenly vaccines seem so easy. You've got a delivery channel, you've got a kind of single buyer, and everything's on a schedule. MCH seems like the wild, wild west. So a lot of new challenges there, and it's actually an interesting point because as we look across global health, there's some nuances and differences in the different products and even how we think about devices versus vaccines versus other products. So let's try to make this a little real by diving into some examples. And I'll turn back to Gary. And you have many products you could choose from where you really have been able to get a lot of your products into developing world markets and been quite successful. You also have a new one that we've been working on together where you're struggling or tackling some of these same challenges. Maybe just quickly try to touch on both of them and talk about some of the lessons with thinking about successful introduction and scaling and how you've been kind of approaching it.
Sure, so let me touch briefly on another successful example, and then let me talk about the one you mentioned that we're working on together. So in the early 2000s, when antiretroviral access for HIV and AIDS patients was beginning to scale up, and there was huge investment in that, and everybody understood you take a pill and it prolongs your life, and everybody understood the condom. And I remember sitting back thinking, all people are thinking about is the condoms and the pills, and there's a lot that has to happen in between to make this work, because among other things, you'd had to build health systems capacity, you needed the proper laboratory tests to know when to start antiretroviral therapy and to monitor the therapy, and people weren't talking about it because when you start talking about the lab, most people glaze over. And so we started to partner with the Clinton Foundation in early 2004 to create broad-based access to CD4 testing, which is the critical test that measures how much your immune system is depleted, and it's the staging test for antiretroviral drugs. And at that time, not only was the testing inadequately accessible, laboratories didn't exist. So we had to engage in fundamental laboratory system strengthening, working hand in hand with partners. We got into an access agreement with the Clinton Foundation. President Clinton himself was involved in it. And I won't go through all the details, but lo and behold, within 5 or 6 years, there was broad-based access to CD4 testing throughout sub-Saharan Africa. And in the process, we trained over 8,000 lab technicians in 60 developing and emerging countries to help make that happen. So that access point was achieved. Now think about that circumstance. You had President Clinton himself, the Clinton Foundation, you had PEPFAR, you had Global Fund. There was a lot of momentum behind it and the whole antiretroviral access momentum, but still it would not have happened on its own, and particularly because of the technical side of this and the need to build the capacity. Let me shift gears to maternal and newborn health, which is where we're putting most of our emphasis today. And for those of you who don't know, in 2013, there were 2.8 million newborns who died, first 28 days of life, and 2.6 million stillbirths. That's 5.4 million deaths, not only under age 5, under 28 days of life, mostly preventable. And newborn mortality without the stillbirths now represents almost half, 44% of all under age 5 mortality. So as all the progress has been made under age 5, the ratio of newborns has been going up because it's a complex set of interventions. You know, my first daughter was born at 27 weeks gestation. She was 1 pound 11 ounces at birth, and she spent 75 days in neonatal intensive care. And I've got a real indoctrination being in the hospital every day about what that care was about. Her therapy regimen in 1990 was over $200,000, 1990. Imagine what it would be today. You can't take that and transfer that into a developing country neonatal unit. I've traveled in 70 countries. I've been in hospitals in most of them. You go into a neonatal intensive care unit in many developing countries, you may be lucky to find an incubator there. You won't find much else. So how do you bring about the innovations that can replicate what happens in an intensive care unit here, but at far lower cost and far more accessible? This is the fantastic work that you started, Saving Lives at Birth, was to stimulate the innovations, but now how do you get those to scale and into the hands of the people who need them? So the device we're working on together, and I'll keep this short, is called the Odon device. I hope you've heard of it. If not, Google it, because it's a really colorful story invented by an automotive technician, an automotive mechanic in Argentina, who came up with the idea in a dream after seeing a YouTube video of someone removing a cork from an empty wine bottle, woke up in the middle of the night, told his wife he could deliver babies this way. Had some experience
We'll
in his family.
demonstrate for you at happy hour.
For volunteers, we take volunteers. But he came up with this idea. He got some people to bring him to an obstetrician in Argentina who invited somebody in from WHO. The doctor loved the idea, much to everybody's disbelief. Championed it in WHO, brought it to Saving Lives at Birth. It won in round 1. And at the World Economic Forum meeting in Davos, the World Health Organization presented it to me in the World Food Program 10. And even though BD had really no business in that area of obstetrics and gynecology, it looked like something we could help with, and after some internal debate, we decided to develop it. And we're now well down that path, and it's a device that would replace forceps or vacuum assist to extract a baby when there's prolonged second stage labor and the baby gets stuck in the birth canal, which is responsible for almost 10% of all maternal mortality, and that stage of delivery is about 25% of newborn mortality. It's a big deal.
So quickly, how are you thinking about challenges around scaling?
Well, there's a
It's still
lot of
early in
challenges.
development.
So it's still early in development. It's about 2.5 years away. It's an intensive process. Right now, what I'm fixated on, 3-4 years out, is how we're going to get this in the hands of where the places where most of these mortalities are occurring. It's that lower end of the market. And if we end up introducing, exactly to your chart, at low volumes, this will cost us 6 to 8 times more to make than what we could feasibly provide it for. If we get the volume up, we can drop that cost down 80% and make it accessible. We're going to need advanced market commitments to do that, because that section of the market won't be able to do it on its own. Unless we give it away, we will give a lot away, but we can't give everything away. So that's where we are right now. It's exactly the scaling question that you used. But we're trying to take the knowledge we gained on immunization, CD4, and other innovations and apply it here. Much of that is applicable.
So great. So Krista, let me turn to you. And your group is not the size of BD.
No.
Don't have as many folks at your disposal, but you've been able to take an innovation brilliance and be able to actually, you're in 23 countries already, introduced in 23 countries. And so what were some of the big challenges that you faced in coming up with a partner, introducing even just in India?
Sure.
What were the
I'll give
highlights?
a little bit of background about DREV's model too, maybe that will help. So we design world-class products, meaning that our products are on par or better than the best products on the market. And I really make this distinction because I think we've had a long history of good enough products for low-income populations. And my perspective is that no, everybody deserves the very, very best quality products. The second thing is that our products are market-driven, and that means that we raise philanthropic money, grant money for the R&D part of the process, and then once the product hits the market, it needs to be totally economically self-sustaining. That means that people buy our product, that means profit margins are built in, so that we shouldn't really need any more donor push of the product. The reality, of course, is that the markets we're in are not necessarily efficient, and so we found ourselves pushing products a little bit, but actually, we're in 23 countries with purely organic growth for Brilliant. So we haven't done really any pushing there. The third thing to know about us is that we're user-centric, and we actually say we're user-obsessed, meaning that it's much more than just the users and what we call stakeholders here in Washington, but the environment, like what are the voltage surges like, how often is power out, all the sorts of things you need to have a product that keeps working, right? So Wendy mentioned Brilliant. So Brilliant was introduced to the market. This is our first phototherapy device in late November 2012. And we've scaled into 23 countries. over 1,100 products sold. And this is primarily because we have a partner in India called Phoenix Medical System, and they're the biggest maker of neonatal equipment in India. We specifically chose them, and we chose them because they had an excellent reputation in our biggest target market, which was India. And what led to that reputation? They respond to servicing calls faster than anyone else. So when you're just an impact, it's not just getting the product there, right? It's making sure the product keeps getting used. I thought I would share, though, one of the lessons learned we had in scaling Brilliance up, because everyone kind of likes to hear about failures or lessons learned. When we put Brilliance on the market, so some context, Brilliance is $400 US if purchased in India. It's $500 plus shipping and your local tariffs if you buy it outside of India. And for context, a standard phototherapy device in the US is $3,000 or more. Our stiffest competition in India is GE Lullaby, and it's somewhere between $800 and $1,500 depending on who's buying it. However, when Brilliance first went to market, we saw that it was actually scaling internationally faster than we expected, and distributors in other countries were starting to buy it. And in the Philippines, it turned out the distributor was buying it at this $500 price point plus the shipping, and then they were turning around and selling it for about $2,700. So it was a very interesting lesson learned for us because we designed this product to be affordable for our target users. But we didn't quite think all the way down the chain. So how did we address this? We actually started to get involved in doing due diligence in local markets and vetting distributors for our partner Phoenix to make the distributor agreement with, an exclusive distributor agreement with. And what we were looking for was price transparency, willingness and desire to serve low-income hospitals, because Brilliance is really designed for district-level hospitals and above, hospitals that have a neonatal intensive care unit or a special newborn care unit. And then we also wanted to be able to collect impact data. So one thing about Brilliance is that we designed into it, it tracks its own usage. So we can pull the data off the machine and estimate the number of babies treated. And if you looked at the bio and said, oh, 40,000 babies, how do they know that? That's how we know that. And in fact, if you're really interested, we have the whole set of algorithms and assumptions of how we get to that number online.
Great. So maybe let's go back to thinking about the user. You talked a lot about being user obsessed. Robert, you have built up an entire practice about being user obsessed. So talk about how important it is to understand the end user, where that comes into play, at what point you should start thinking about that, and sort of share some of your thinking there.
Well, I mean, obviously I share Krista's perspective and really appreciate the fact that this is such a core theme and consistently reinforced throughout the guide, not just at the beginning, but kind of throughout the process. And I think even as we're seeing, I think, a greater appreciation for this question of kind of user kind of appropriateness, user adoption, fit to the context of use, even as we're seeing a greater appreciation of it, I think that we're definitely still experiencing a kind of a mindset that this is a task that's done once. Maybe at one point in the process, you tap and measure some user needs, and then you kind of run with it from there, you know. And obviously, working in the private sector on product development, there are some assumptions that you make around how you define a product. In a lot of the cases in global health, there's very, very poor market data, and there's a really high set of aspirational assumptions made about why people might change the way they live and use something. And these things are for anyone who's worked in the space of product design, when you sit down and talk to somebody, like we're working right now with some folks at Johns Hopkins and Japaigo around some product innovations, these things keep you up at night. If you spend time designing products and been through that process of a lot of iteration and testing, it keeps you up at night when you know people are making very optimistic assumptions about user behavior, and they're doing it based on very little concrete data in terms of involvement.
Can I ask you a question?
Yeah.
How do we keep from making optimistic assumptions? Because I think, to me, like that's one of the challenges we have in our sector is to actually get real about the assumptions we make.
You know, I'll give you an example. I think it comes back to this sense of people being very need-driven. I'll give you two examples. So one of the first products I worked on in this space was HIV-related. And going and visiting communities in KZN in KwaZulu-Natal, it wasn't just that HIV wasn't on the top of the list of health concerns for young girls and women living in townships. It wasn't even on the sort of top 10 list of concerns, period. And as much as you would think in a place with 40 or 50% disease burden that it would be a really pressing concern, it was not. So part of it is that we think big need means motivation, means overcoming barriers, means big product opportunity. And in particular, on this recent work we did, we were looking at cervical cancer, which is one of the most kind of rapidly growing health concerns globally. Even though it's a non-communicable disease, it is growing really rapidly in terms of the number of women it affected. And I think, again, there was an assumption that that big need meant that there was a really great space for innovation. And it meant that a lot of the limitations that are there, you felt like there's some way to sort of change the product enough that you can overcome a couple barriers and change that dynamic. And I think the way to overcome it, I think, is more early and direct engagement with people and communities and listening to them honestly and trying to understand and prototype and test where a product fits much more quickly. I think second is accepting that the segment, coming back to Gary's discussion, with the greatest need may not be the greatest starting point for your product. I think another thing is understanding how much both your end users are influenced by other stakeholders, as well as how much those other people really are going to determine the success of your product. And I feel like the design community that I come from is at fault a lot of times by taking the dollars, the $100 that's spent with us, and spending all that time modeling end user behavior, and coming back with kind of this wonderful synapse connection between the need that the product company saw and the behavior of the end user, and skipping everybody kind of in between. And when we were doing this work on cervical cancer, we discovered a couple of things, probably fairly obvious to people in the market, but most of the places where people get care, nursing homes and such in India, they don't want to touch cancer. It's not a topic that they want to bring in. And if you bring a lower cost device that allows them to offer that service, they still don't really want to have it in their practice. But there are other applications for the device, a cryotherapy device, beyond cervical cancer. So you can kind of change your point of view and maybe build a market in a different way. So, these are all things that I think we can all kind of get better at. And it's funny because I feel like we kind of learn them on each product and then we kind of forget them a lot. Yeah. I think one last other thing I would throw into the mix is I see very few organizations that are building up knowledge. So you go work with someone like the Gates Foundation or USAID, and so much focus on getting to, let's say, adolescent girls or young mothers with just a battery of interventions, and so many different groups studying and trying to learn about that behavior, and there's just no capture and consolidation of that knowledge. So honestly, there are a lot of, I think, great opportunities to improve this process. But again, it starts with kind of reframing how you think about who the user is and how you look at their world.
So it's been said that one of the best outcomes is actually your product that actually works for your end user, but a second best outcome is one that doesn't, but gets killed early. Did anyone have an example of something where either you're, through user understanding, really understanding the markets early on, got you to kill a product or pivot in a certain way? Maybe we won't talk about failures, but to change so Steve or Krista?
I'm happy to jump in too.
I was going to, there's times when, we had a vision for a certain product a number of years ago to make it easier to deliver the ARV for prevention of mother-child to the newborn. And we were working with a pharmaceutical company that was the innovator, and we took off down a pathway, and it turned out to be just technically not possible. You couldn't store the drug in the particular type of container we wanted to store it in for more than 6 weeks. So we had to pivot and rethink that what we're doing is making that nurse who's administering the counseling program to the pregnant HIV woman, what do we do to make her job easier so she can give the drug to the mother so the mother can take it home? And it wasn't in a beautiful pre-filled syringe, but it was a little plastic pouch that she could put it in and a syringe. And so I think it's, again, pivoting on the user. And not just the user being the person who receives the care or uses the product, but that whole ecosystem of, in some cases it's providers, in some cases it's the distributors.
I want to come back to a moment your point on optimism, though, and say that you need very optimistic, persistent people working on these. Someone who's this is taking on some of the world's greatest, most deeply embedded health challenges among the hardest to reach populations. and trying to overcome those barriers. And you need to have a little bit of blind optimism, hopefully not, interfering with the appropriate questions and steps in product development, but this is not for those who find fault too easily.
No, agree.
And I would just add that notion of pivoting, I think, gets to a core question, which is you have to have a product development culture in which product management and product leadership can pivot. And they're not wed to a vertically oriented agenda. They're not wed to a donor agenda. And great product organizations, it's very interesting. Product managers have a lot of autonomy and power. And they can work very horizontally across an organization, and they're given a lot of free will to sort of break rules and change direction. And I feel like that's one of the hardest things when resources are so scarce and when needs are so big. We get really kind of like a deer in the headlights, and we're really worried we're spending the incremental dollar in the wrong place. And we might be, but we have to learn, like Steve's example. And at the end of the day, that ability to pivot really comes from a sense of independence, and it's empowering people at a much lower level than you would typically see. And it's letting them make those choices and finding a way to kind of preserve kind of whatever the broader goal is, and adapt. And I think that that's, really, to me, one of the core messages of this guide. And if organizations are going to take it to their heart, they have to figure out how to unlock that kind of product entrepreneurialism within their businesses and within their organizations, and free it up from some of the impact and measurement and evaluation agendas that just are kind of the monkey on everybody's back.
Yeah. So let's pivot and talk about tools. So we've got a nice array of tools. Dave's slide, his eye chart had lots and lots and lots of steps from end to end, which could be a bit daunting. I actually talked to a sort of ex-pharma guy who went to lead a biotech company, and he said, yeah, I brought all these tools from my old company and plopped them down on this biotech company, and the company almost fell over on the weight of all these things. It was too much. And so how do we think about thinking through what is most necessary, what do we have to do that's critical, that we will fail if we kind of ignore these steps? Are there other pieces of this where we can do a little bit more of a back of the envelope approach? How do we sort through this laundry list of activities? Any of you want to?
Well, the first thing I would say is, we're not talking about toys or something like that here. We're talking about products for medical care that have life or death implications for patients, and in highly regulated industries, national regulations, international regulations, WHO regulations. So there are steps that must be followed relative to product development, relative to clinical trials, and working through the regulatory process.
Can I make a point on that, and that just to emphasize this guide itself that we developed, this was really the delivery side of this, right. And the kind of all the steps necessary on the product development side were not ignored. They were just kind of really trying to apply the delivery lens. But just to echo your point there, and how critical that is.
And there's a lot of complexity in this. You'd be amazed how much actually goes into developing a new device, a new drug, and so forth, a new diagnostic. On the delivery, where the intuition comes in, that was your question, I think the knack, for me at least, comes in early in the process. You see something, you understand the need, and you sort of put the pieces together based on your experience and have a hunch as to whether or not this could be a successful approach. That hunch is not going to take you all the way through the steps, but it may be enough to get you off the ground. The delivery side also gets very complicated in a different way, less related to regulations, more to understand what does it really take to get broad-based adoption in places where few have achieved that, in hard-to-reach populations that, by definition, are at the lower end of the equity scale. I tend to be more intuitive than most who work in this place, but there's a lot of discipline in the process as well.
I actually want to bring some good news to global health on the it's hard issue. I used to work in agricultural equipment in Africa, in Kenya specifically, and I have to say, medical interventions in some ways are easier than water pumps, in the sense that the medical environment, the hospital environment, is not radically different from culture to culture as compared to farmland in the uplands versus farmlands by the coast versus a preference for this crop versus a preference for that crop. So I do want to keep it in perspective. Yes, this is hard work, but I also am a true believer that if you stay focused on achieving impact, solving the problem, not just developing a product to market, but solving the problem, then very quickly having tools like we're starting to have now, thanks to USAID and PATH, you can quickly hone in on what are the things I don't understand. And when we think about scaling with DREV, we really focus on three things. One is the need, and that really is what drives us. The second is the market, because we do have a product that needs to be paid for, understanding the price sensitivities. But then the third thing, which is really critical in how we prioritize market entry, is barriers to scale and barriers to the market. And this can be anything from regulatory, registration, shipping, tariffs. Those of you who don't know, Bangladesh has 100% tariff on prosthetic equipment coming into the country. And then just protectionist policies. So we actually go through country by country and do due diligence on all of these sorts of things and then prioritize the countries in terms of what can we enter sooner, what do we need to make a longer term investment, and then kind of just it all shakes out in a list.
Wendy, to both your point and a point Robert made, I think, at the early stage, we as a global health community, I think at times have put all our eggs in one basket. It's like, well, we got to prove the technical proof of concept or we go overboard on we're going to go talk to users until we're blue in the face. I personally think we need to do a better job I'd rather see the resources prioritized that we touch on each of these subjects across delivery, even if we have to do those a little less rigorously, but that at the early stage we do look across sort of all these dimensions.
Yeah. And let me pick up on a point you made, Krista, where you're really starting to think about how you think about where to introduce a product, where to go first. How many countries you can introduce in at once. So as we think about it from a donor perspective, often we have the luxury of trying to drive uptake where you have multiple manufacturers. So how we might look at that is even a little bit different because we're thinking about where we could be focusing our resources in terms of the angle where we're providing support. But from a company's perspective, an innovator perspective, how do you think about where to introduce and how quickly?
So I would agree with Krista. It's driven by the need. So there are reasonably good indicators on most, if you talk about maternal and newborn mortalities we were speaking about before, we know India and Nigeria are the two countries that have the highest burdens. So start with the need. Understand what within the economics of the health system allows that market to develop through a natural business model, what might require more cross-sector collaboration to stimulate it. Access to the facilities, where through your own organization or through distribution can you get access? What will be the training requirements? You mentioned before servicing is a critical factor. Do you have the capacity to serve if it's a piece of capital equipment, or can you access the capacity? These would be factors that would determine where you go first. Yeah.
And you're coming from the corporate perspective, so clearly often, maybe always, or at least most often, you're really thinking about maximizing profit. Public sector, we're going to be thinking about maximizing health impact, not that companies aren't about health impact as well. How do we, when we think about collaborating, which you mentioned is so important, how do we think about finding that common space, which, Krista, I think you even talked about, that alignment where we try to bring both of those objectives into alignment?
Let me just jump in if I can. I think motivation, alignment and motivations, for me, is the number one factor in determining who you work with. And you'd be surprised, probably you wouldn't be because you know us well enough, how profit maximization is a broad thing. We have to perform well as a company. We have to deliver every quarter. We're a publicly traded company. We have to do that. That's our entry ticket. But when we work in these fields, our motivation, I would say, is extremely well aligned with public sector agencies, nonprofits. We're not trying to figure out in global health how do we maximize the profit. We're trying to figure out how do we maximize the impact.
I think one of the key things we're touching on too is this issue of partnerships, and I want to be really clear. So DREV is 11 people, and we're only able to bring Brilliance to market through Phoenix, our partner, but there's a lot of other partners that need to come in for us to be successful. And this issue of alignment is key. Phoenix is a for-profit. And one of the things that was interesting to us as we've kind of gotten better at being partners too is that they actually use Brilliance as a loss leader in some markets because they sell very affordable, high quality products. But new purchasers in low income countries that Phoenix didn't serve before are interested in Brilliance, and then they end up buying a lot of other Phoenix equipment. One thing I want to mention, like going back to the system approach and thinking more about delivery from the very beginning. And I see, just to be clear, I see product development kind of like this, and you're hopefully moving in this direction, but the activities, you're going back and forth and relearning and testing and going forward. But the way we choose our delivery model is really on how we can best reach our target users. So with Brilliance, we partnered with Phoenix Medical Systems because they had the network in India. They were they were very trusted, and they had other neonatal equipment. They were very established. With our knee, we actually are managing the delivery process ourselves with a contract manufacturer and distribution, which is a high risk, again, for a small company, but we also believe that we're best positioned to serve the market. And it's a smaller market, it's much more fragmented. I actually just learned from a colleague yesterday that the processes in India are actually starting to talk more and network more through WhatsApp. So there's a lot of really exciting changes too that I think we're living in a very exciting time where small, scrappy organizations like us can take advantage of the changes that are happening on the ground and the innovation that's happening on the ground with our users and with processes and with clinics and with these what we call small micro hospitals, these little private hospitals that are emerging in response to the public healthcare sector maybe not working.
So we have, thank you. We have a phenomenal audience here today as well, and actually pretty diverse group. So I want to bring you all into the conversation. So we're going to open this up. I don't know if we have microphones, but we do, microphones in the back. So just raise your hand, they will find you, and you are first up.
Hi, thanks for this great conversation. My name is Stephen Ram. I'm with GRM Futures Group. And I love the story about your upcoming product, the Gary story about the Odon device. There have got to be tens of thousands of people in developing countries who had a dream about removing a cork from an empty bottle of one kind or another. Not all of them are device-oriented. It might be tweaking an ambulance system. It might be a service, a methodology. How does this apply beyond the guide and the workbooks and tools there? How are any of you, or perhaps Wendy, best for you, how do we support innovation really beyond grants and beyond tools and really surfacing the ideas from those thousands of people where they are actually closest to and know their markets best?
Yeah. Well, I mean, I can say certainly we've had just a great experience over the last 4 years with our Grand Challenge model, and it's completely changed the way we're doing business and how we're looking for solutions to problems. So for those of you that don't know the Grand Challenge model, it is a grant program, but it is one where we put out a challenge. We've got a problem we don't know how to solve, and we're calling on the global community to come up with new solutions. And the thing that's so exciting about it for us is it sort of flipped our traditional grant-making model on its head, where we used to just give big chunks of money to folks, maybe one of whom was on this stage here today, but many of the folks who are very good at getting grants. But what we did is really we're able to open it up to the world and get the Jorge Odons of the world to be able to have an outlet for their ideas. It's just one way that we're doing that. We need to continue to think about how we can foster innovation, how we can source innovations from those closest to the problem, and so we're continuing to even innovate on our Grand Challenge model, how we can incubate ideas, and so I think there's lots of room for continuing to do better, but for us, even Grand Challenge has been a great way to sort of open up our eyes to how we can solve problems in completely different ways.
Yeah, I would say, in fact, you've done such a good job at you and Rice University with their Global Health Development Program, and Harvard and a number of other places, Stanford. have done such a great job stimulating innovation that for a large organization like ours, we actually don't need to think about innovating in this space, which, we could, but it relieves us of that task. We can put our focus on taking the innovations to scale, which is, I would say, 85% of the work happens after the innovation is conceived and sort of brought to a concept phase. All the things that have to be done after that. And I think we're actually going to be the first, certainly among large companies, to take a grand challenge as Saving Lives at Birth innovation to scale.
Hear, hear. All right, more questions. You guys are way too smart a group not to jump in on this conversation. Okay, over here.
Hey, my name is Samson. I just left a... Thank you. Hello. My name is Samson. I just left a faculty position to start a nonprofit to work on some of the things that have been discussed today. Krista and Robert have both mentioned the need for data. And as a person who's into diagnostics, it seems to me that that's a great opportunity for informatics type projects. Has anybody ever thought about business models for acquiring data?
Do you mean like tools for getting the data we need, or what do you mean by business model?
Well, I can set up the infrastructure to collect data. Let's say somebody's got a CAT scan in Ethiopia. Actually, I'll be very specific. I have a client who's building a CAT scan in Ethiopia, and I can have that data sent to me at Hopkins. So it's a very easy thing to do technically to collect that data, but how do I make money doing that?
Great question. Yeah, and I love that you brought this up, because this is one of the drums I've been banging. Is I would love to see more funding put into impact assessment and impact assessment throughout the product development process. And what you're talking about to me in some ways is the use of that device. Where we see insufficient information is just around like even basic market data. I'll read a market report on India for medical devices and I'm like, this totally does not jive with what I'm seeing on the ground. And it's very hard to understand, how much do you follow your instinct? How much do you rely on local partners versus these nicely published reports? So I would actually say it's across the spectrum that we're missing data. We've really prioritized at DREV doing affordable, scalable impact assessment on all of our products, which is how we ended up designing into our product, how it kind of self-tracks. But I would love to see you and groups like you, or organizations like yours really funded and help out groups like us. Because at the end of the day, our sweet spot is really product development and making sure the product gets where it needs to go. It isn't necessarily designing products around data collection. Can I just add one more thing, though, when we're on the topic of data? I really want to push the idea that as a sector, we want to be data informed, but not necessarily data driven. And I say this because I really see differences on the ground, and Robert referred to this too, about what users want and what users prioritize versus what the experts say the biggest problems are, because we have data. And the challenge with that data is like the data is this, but the world is like this, So I believe very much in data. I think we could be collecting a lot more of it. I'm a huge believer, but I also want to keep in context the use of the data and the understanding of where the data comes from and the value of it.
Yeah, just to build on that, I think that even thinking about it in terms of impact evaluation or assessment is sort of, to me, still kind of the wrong model to look at value and value creation. I think certainly there is a need for funders and many participants in the ecosystem to provide data that answers those questions that you committed to at the beginning. But there are a couple of really consistent pitfalls I see around data happening over and over again. One is very vertical uses of data. There's no point in setting up that link you've talked about just to get data off a single CAT scan, right? It's just not, if you're going to enable data, you should be enabling it not just for to answer single vertical questions. The second is that the people who are collecting the data and providing that data, particularly folks like community health workers, and we're working on a national scale program in Rwanda, 40,000 community health workers collecting data, they don't get any value back from collecting that market data. There's nothing that's benefiting their jobs. It's just adding one more task onto their list. So the whole data story is, I think, being looked at very much from a technology and engineering perspective. I think it's one of the huge areas where we need to kind of pivot our thinking and think about how we understand the way information and knowledge is valuable to people at every level. And we think about how data is shared before we think about how we evaluate and assess and prove the one thing that we care about. And I think it's certainly an area where I'm hoping better decision-making emerges, and there are startups that are doing some really interesting things both at the crowdsource level and at the sort of infrastructure and standards level. But at the same time, I think that they're still doing it because they think in some way it's going to sort of just be there to answer the one question they have for their donor, and it's not going to strengthen the whole ecosystem. And it's not going to be used in real time. It's not going to be processed and shared more openly. And those are all the places where I think, particularly for health, we're seeing data in a straitjacket that we don't see in areas like financial inclusion and other areas where we're working, where there's so many more business opportunities, so many more marketing opportunities to sort of take advantage of that data, and an ecosystem that kind of creates value around it.
So if I can make a quick comment as well.
And then before you do that, I want you all to think, I want to know how many more questions we have. So start raising your hand a little bit while
Because we can just
Gary
keep talking.
finishes.
With each
So you
other.
do it really quickly.
Even after he's done, we'll keep talking. We're dealing with issues that are at the intersection of public health and health care. We're dealing with individual health and we're dealing with population health. And public health requires data, in my opinion. So I think it has to be a critical part of the systems we build upon. Also, and this may be a little bit the optimistic side of me, but I would like to think that newborn mortality in particular, and also to a degree maternal mortality, have been so neglected that there's a finite series of interventions that if they could be brought to scale can have disproportionate step function impact on reducing those mortalities. Jaundice being one, dealing with preeclampsia, dealing with postpartum hemorrhage, obstructed labor. There's not 50 things that need to be done. Now, that won't get 100% of the mortalities, but maybe 50 to 80% can be reduced with a finite set of interventions that for the most part haven't been mobilized almost at all in the lowest resource settings. We're going to need access to data to demonstrate whether those step function reductions in mortalities and morbidities are occurring. The last point I would make is it's not going to be long before all these devices are talking. All the Internet of Things, and it's not far off. It's going to come quicker than we expected. It was in Davos 2 weeks ago at a meeting on this. It's just a matter of a few years before all that data is being transmitted. What are we going to do with it? How are we going to collect it? How are we going to make sense of it? These are things we need to figure out.
Yep. All right, so I saw at least two. So we have one here. There was another one in the back. All right. So we have 3, maybe 4. I'm going to have you guys really quickly. We've got 4. Really quickly ask your questions. We're going to try to keep track of them, and then we're going to give you very quick answers before we do final words.
Somebody's
All
got to
right.
start.
So you start. Go for it.
Hi, Samir Buhamad. I'm with Global Health International Advisors. I have 2 questions actually. One was kind of towards Gary, and then one was just general. I know with the Odan product that you kind of founded in one of the national markets and then took that project and brought that on the larger scale. How many of those products do you guys deal with? Is that a common thing, or is that a rare occurrence that you guys found that product? And kind of what is the rate? Is that kind of like what the future trend is looking like, or is that just an anomaly that happened in that circumstance? And then another question that I kind of have just generally is how much of the financing and the funding that you guys get, how much of it is luck and how much of it is actual going out and getting those grants, and how sustainable is that system that you guys have in that sense?
Okay. Question 2 in the back.
So I'll go.
Okay. Whoever has the mic.
I'm behind the column. Hi. My name is Jahara Otieno. I work for Concern Worldwide on an initiative called Innovations for MNCH. And so I think my question for all of you is, we've talked a lot about product development, and so I want to know how you apply kind of the lessons that you've learned when you're developing the programming that sits alongside the products. When you're developing behavior change messaging, or how you're doing your training. A lot of the work that I do kind of focuses around the support you're giving to CHWs, not necessarily the device you're giving them. And so it will be really interesting to hear kind of what your experience with that, how you think you could do that. That would be really helpful.
Excellent. Okay. Back here, please.
Hi, I'm Selena Shawkin from Japigo. And my question is that when we're talking about the ODON device costing 6 or 8 times more than what people could really afford to pay, and we think about what primary health centers have in their health centers and how much they need and how little funding is really going to those health centers, there's a huge amount of products that we need to get out there in so little time. Are we going to be dependent on donor funding in order to get those products out there? How do we create a market? And so what are the risks of designing in order to get the donors to pay for a product versus designing for a market?
Okay, great. All right, and the last question.
Hi, Gary. My name is Rose McCabe. I'm with PwC. Gary, I heard you talk a little bit about the importance of funding and financing and how that's often a common pitfall. And I was wondering if you guys had a perspective on how you can use alternative financing mechanisms to reach this customer base and to increase the access. A few on the top of my head could be micro health insurance or microfinance health solutions. I was wondering if any of you had a perspective or had experience with implementing those solutions.
Okay, great. So I'm going to recap in case you guys have not kept track of all of these. So number 1, finding ODON anomaly or trend. I'm taking liberties here.
The headlines.
Number 2, how much financing is luck versus getting grants. 3, applying lessons for programming around the product. So this is the training, this is the BCC piece. 4, we've got so designing for donors versus designing for markets. And then 5 is using alternative financing to reach the customer base of microfinance and microinsurance. So each one of you can maybe just give a quick answer to any question of your choice, and we're going to wrap up.
We've worked with microfinance around household water filtration as a way to allow a consumer with less economic power to basically purchase over time. But a lot of the medical devices we're talking about here aren't actually consumer purchased, so it's going to be different in that case.
Great. All right.
Yeah, I'd like to pick up the sort of service and program piece because we have been talking a lot about products. And not only have we been talking a lot about products, we've been sort of without, I think, admitting it, leaning very heavily on devices and a certain kind of med tech or sort of, certain categories of products. And the beauty is we live in a world in which the people and the communities we're interacting with, there's no hard boundary between a product and a service. And service delivery, in many ways, if you think about kind of the issues we're talking about, service delivery is probably the biggest pain point across everything, whether it's community health worker layer or whether it's facility-based. So, when we're doing the research that we're doing, coming back to your question, and looking at how we understand how a product, whether it's a piece of, whether it's a mobile messaging system, whatever it is, how it's going to fit into someone's life, we're trying to map out all the touch points in that journey. We're trying to figure out who the stakeholders and influencers are. And so we're learning a lot that should be built into an integrated program. And the challenge really is that a lot of our clients segment these things. So they've got one part working on product R&D, and very often the part working on programming and particularly behavior change communication, they're very separated. That second part is often less well-funded and less well-respected. And so we see it as part of our job, bringing that together and taking the engineers who are developing the product and putting them in situations, this may sound goofy, where they have to do some improvisational acting to talk through not just the product, but what a conversation someone's going to have with a service provider about the product, how they're going to hear about it, what they're going to tell their friends about it. Really trying to place people who are at the front lines of kind of R&D and technical product development into that sort of more service-oriented context. And I kind of feel like, coming back to Gary's point, there may be 6 or 8 sort of targeted interventions today that could address most of the problems. But right now, what's hobbling them is not manufacturing and the pipeline for scaling up product development and service delivery, typically. And we need integrated approaches to service delivery, to testing, improving, and investing in better service delivery models. So
Great.
I think I'm glad, it's a missing topic today, so really glad you brought it up.
Great. All right. 30 seconds on one of the remaining questions.
All right, and I'm going to try not to answer all 4 questions at once.
Wow.
Okay, I actually...
Buy you a drink if you do that.
All right, it's a deal. Okay, I am going to take the device perspective because that's what we do. But this is the thing. I don't want us to overcomplicate things. If we are starting with a problem, not a product, we're starting with a problem, and we understand all the, as best we can, all the constraints, and we're constantly testing that. And this includes affordability, getting the product to the users, all of the issues for impact, then often you don't deal with behavior change. You don't need to convince anybody that they need to use this product because you're providing a product that someone wants to use, and can afford. And this doesn't happen across all areas of medical devices, but I can tell you in the sectors where we're working, we have been able to do this. And again, like, you're not going to see this in vaccines, but you can see this in certain areas. And so that would be my answer, is starting with the problem.
All right, rapid fire. So national versus global. Most of these needs are not contained in one national area. So typically we look at a global or regional basis, developed, emerging, and developing, emerging, developed, and we try to maximize the application. Luck in finding funding access, I'm waiting for that. You know, most of the funding access we get is as a result of a lot of effort and hard work. Dependency on donor funding, designing for donors rather than designing for market. It's a simple principle here. You try to find innovations that have multi-market potential, and you can use the developed markets to subsidize what happens in the developing markets. There's always a segment of the population that won't be able to afford anything. I mean, auto-disable syringes sell today for about 4.3 cents each, and if it hadn't been for Gavi, there would not have been mass adoption because the places that are hardest to reach wouldn't have been able to afford 4 cents. But we would look at the profitability in Western Europe, US, China, India, the higher end of India, as subsidizing a much lower, barely sustainable profit in other markets because you can earn the profit. And alternative financing mechanisms, impact investing is a field that's really emerging now. We're talking with an impact investor about our next set of innovations. They're seeking a return, but that's okay. They can help us manage through co-investment, and once we're in the market, we can give them a return on their investment. I think that's a model that's really going to grow.
Excellent. All right. Well, there's going to be more to come as in the happy hour, which we're eating into right now. I just want to do very quick last words from our panelist in about Twitter size sound bites. So all of you tweeting out there, you can tweet these answers. But really, the big question and the reason why I think we're all here together, I think donors and innovators alike often both suffer from getting all wrapped up in the innovation itself and tend to neglect all of what's necessary to think through on the delivery and what's necessary to successfully introduce and scale. So what advice do you have either to donors or to innovators to be able to bring that much more of that end-to-end perspective and make that investment in time, resource, effort around the scaling side? Twitter version.
Think comprehensively, act in very concrete increments.
Iterate and test your ideas early and often. Anything is prototypable.
I love that, and I would also add, a product's not done until you've reached impact, and when you've achieved impact, then you've really done something.
Align motivations, align investments, align purpose. Picking up on your word of alignment is absolutely critical here.
Okay, excellent. Well, please join me in thanking our panel. It was a great discussion. And now we invite all of you to join us for drinks and food and a nice happy hour. Thank you.
Can I stay up here so it gives me better stats?
You'll have to ask the other. If they're okay with it, I'm okay. Okay, you don't want to